All right, today we're going to step inside the super high-pressure world of the emergency room. We're going to decode one of the most urgent and frankly terrifying mysteries they face: chest pain.
You know that feeling? It sends a jolt of pure fear right through you. That sudden tightness, that sharp feeling, or that heavy pressure in your chest. Is it just heartburn? Or is it something you absolutely cannot ignore?
For ER doctors, this isn't a rare event, it's a daily reality. The second a patient comes in clutching their chest, it's like a switch is flipped. A well-rehearsed, incredibly high-stakes protocol kicks into gear. Every single second counts.
But here's the thing, this isn't guesswork, not at all. Doctors follow a rigorous, methodical playbook that's designed to quickly sort the truly life-threatening stuff from the less serious. And today, we're going to walk through that exact playbook together. The race is on the second that patient walks through the door. In these first few minutes, the team isn't even trying to figure out the final diagnosis. They have one job, and one job only: find and stop anything that could kill this person right now.
And just look at this timeline. The clock is absolutely brutal. The goal is to get the single most important initial test, the ECG, done in under 10 minutes. This isn't just about being fast, it's a frantic race against potential damage to the heart muscle itself.
So how do you move that fast without missing something critical? You use a universal checklist, the ABCDE approach. And it's always done in this exact order for a simple reason. An airway problem will kill you faster than a breathing problem, which will kill you faster than a circulation problem. It's a systematic sweep to make sure the patient is stable enough to even begin the investigation. And while they're running through that checklist, they're on the hunt, scanning for these huge red flags. Things like tanking blood pressure, somebody struggling to breathe, or a totally chaotic heart rhythm. Those signal a code red emergency. And, crucially, they're also looking for silent symptoms, especially in older patients or people with diabetes, whose bodies might not send out those classic screaming pain signals.
Okay, so once the patient is stabilized, the doctor completely shifts gears. They put on a totally different hat. They go from lifesaver to detective. And right now, the most important piece of evidence is the patient's own story.
And believe me, this isn't just a casual chat. It's a structured interrogation of the pain itself, often using a framework like this one, PQRST-A. Every single question is designed to pull out a specific clue. What makes it worse? What does it feel like? Does it move anywhere? Each answer helps build a unique fingerprint of the pain, pointing the investigation in a certain direction.
And this is where those clues start to paint a picture. You can almost put them into two buckets. Over on the left, you've got the really high-risk words: pressure, tightness, pain that comes on with activity, pain that shoots up to the jaw. On the right, you have clues that are a little more reassuring: sharp pain that gets worse when you poke at it, or pain that goes away with an antacid. The patient's story itself becomes this incredibly powerful diagnostic tool. So, with these first clues from the story in hand, the doctor immediately consults their mental most wanted list. That handful of diagnoses that are absolute, immediate killers.
In medicine, there's a fancy term for this. It's called a differential diagnosis. But really, you can just think of it like a detective's list of suspects for a crime. The symptoms are the evidence, and the doctor's job is to figure out which suspect is the real culprit.
And when it comes to chest pain, these are the three biggest, baddest culprits on that list. First, acute coronary syndrome. That's the umbrella term for a heart attack. Then you have a pulmonary embolism, which is a blood clot in the lungs. And finally, an aortic dissection, a tear in the body's main artery. Each one has a classic profile, but they can all mimic each other, which is what makes this so incredibly difficult.
All right, so the doctor has a story and a list of suspects. Now it's time to bring in the forensics team. It's time for the tests that can help prove or disprove those suspicions.
So, that's the real question, isn't it? When you have multiple very dangerous culprits on your list, how do you get definitive proof? Well, the answer lies in a series of targeted tests, each one looking for a very specific piece of evidence.
First up is that ECG we mentioned, the electrical snapshot of the heart. This thing can give you instant evidence of a major heart attack just by showing specific changes in the heart's electrical patterns. It's fast, it's painless, and it is incredibly valuable. Next, they draw blood. What they're looking for is a protein called troponin. See, when heart muscle gets damaged, it leaks troponin into the bloodstream. But here's the catch: it takes a little while to show up. That's why they often have to repeat the test a few hours later to see if that level is going up, which is a huge red flag for a heart attack.
So you've got the story, the ECG, the blood test. How did doctors put all of this information together? Well, they use standardized tools like the heart score.
It's a system that combines the patient's story with hard data from their ECG, their age, risk factors, and that troponin test. It crunches the numbers and spits out a score that basically tells them how high the patient's risk is, and that score guides the next big decision.
Armed with the story, the tests, and that all-important risk score, the doctor has to make the final call. This is the disposition decision. What happens to this patient right now?
And that risk score plugs right into a pretty clear decision tree. High-risk patients, like someone having a massive heart attack, are rushed for immediate life-saving procedures. Moderate-risk folks are admitted to the hospital for a closer watch and more tests. And the low-risk patients, the ones whose story and tests are all reassuring, can be safely sent home with a good plan for follow-up.
But, and this is so important to remember, even with all this data, there's a huge caveat. One normal ECG and one normal blood test do not automatically mean everything is okay. This playbook provides the structure, but at the end of the day, it's the doctor's experience and their clinical judgment that acts as the final safety net.
So after walking through this whole playbook, what's the one thing you'll remember? Maybe it's that behind that initial moment of fear, there's this incredibly fast, systematic, detective-like process, all designed to solve one of medicine's most urgent puzzles.